through a craft process, a batch process, and a flow process. But as our good friend the doctor here said, we can go from craft to flow. It's not difficult. Okay, everybody ready?
So all I have to do is pass this.
Right, they're going to request it.
Okay.
Yeah. Now, remember, each of the pens represent a stage in the process. So we can't change the sequence of the process. Yeah, we can't register the patient after we finish the operation. So I've deliberately put the pens in the right sequence. Although you're moving, good.
Yes.
Yeah, reset your standards, good. Yeah. So this is some good industrial control of the stop. Mm-hmm. Yeah. So each of the 1 to 5, you're doing the entire process for the date case. Yeah. So you have to put the 2 X's for each of the colours in place. So what you have to do is request a pen, the colour of the pen, hopefully the colours are clear, or pen number 1 if we keep them in the correct sequence. Our friend in the store will provide you with a pen. When they're finished, you will give him it back. Okay?
So I can't request until he's finished.
Well, no, you can't see each other. You're all working independently. So imagine you're sending an email saying, send me the pen.
Okay.
Because that's what really happens in craft, yeah, when we have limited resources. So you can imagine this is going to be extremely chaotic. And it will be very stressful as we go. So we'll start the clock at the moment I say, is everybody ready? We say yes, we'll start the clock.
And I can do
Yeah.
You have to request for the...
Oh, you have to request.
Yeah, the request for the patient and the request for the pen, yeah? Yeah. So you're going to get multiple requests. So it's going to be chaos.
Yeah.
Yeah?
Yeah.
Because just imagine you're in a different part of the daycare suite, yeah? And you either have email or you have a telephone or a way of communicating, but it's not immediately visual because you're not next to each other as you are today.
So maybe we should do that instead of making it visual.
Just keep it simple to start with, yeah? Otherwise we'll become very complicated and we'll take all day, which isn't bad from a learning experience. Excuse me. Okay, so is everybody totally clear?
Yeah.
Yeah. So that is the quality standard to make sure that the documentation for our patient is correct. Okay, we have to do them in those sequence, and they should be.
What is the significance of 2 X's and not 1 X?
Make it more complicated.
So that there's time.
Okay. There's a big difference of only having 1X and 2X. It takes twice as long, which creates more of a time delay for the next one to come. We used to run it with 1 and we found it didn't make a big difference, as much a difference as craft and flow as it does. So as you get more and more patients, flow works better and better results as you go forward. So it was just to create that
So
difference.
this flows like this and then it
Well,
comes.
no.
Each man to himself.
Each person is an orthopedic surgeon with his own team in his own OR, okay? But they're having to keep borrowing the same piece of critical equipment.
That's the only one.
No, just the one.
You have to go this way.
Yeah. These are the patients, right?
Yeah. So you're going to request.
They give you a
So you're going to say, I need my
Your
patient.
first tool, which is your peak, and then you do the peak and you give it back to him. Then you ask for the second one. If he has it, he'll give it to him.
Exactly. Yeah.
But any patient can come in. So patient
Yes.
is no.
Any patient can come anyway.
Policy.
That is probably more chaotic than normal.
Because you're not.
Okay, now I think everyone's clear.
Yeah. But it's not a test. Don't worry. It's not stressful, but it will be stressful at the end.
So ask and then ask for whatever you
Do you want your patients?
Yeah, patient.
We need to stay ready so that we have the stopwatch going.
You can be ready.
And remember
Security.
the pen has to return to the store, guys. You can't give it to you because you can't see them. You're in a different wall. Yeah? So the pen has to go back to the store. When you finish your 2 crosses, it has to go back to the store. Okay?
I'll make sure.
Okay. Is everybody ready?
Recording is already started?
Yeah. Are we recording?
Is the person who
We've got a video for that. No, it must be recording. Don't worry. 3, 2, 1, go.
I need a patient. Patient, please. Patient, please. Can you send me a patient? Thank you.
Which one?
Now you have to
Can you give me
No, you have to get pink first.
Can you give me
No, no,
pink?
he has to get pink first.
You have to have pink
You have
first.
to use pink
Can I
first. So now you have
Yeah.
Okay.
You can't do pre-op assessment before you've committed the patient.
Pink, please.
Don't have
When it
anything
comes
first
back.
Brown, please. Brown,
Now you have to.
Okay.
Let's try and finish this.
Two crosses. Brown, please. Brown, please. Brown, please.
Pink, pink. First then.
Please do it. Pink.
Pen, please.
Brown, please.
Can't help me.
Yeah, yeah. Give me.
Brown, please.
You have to sit around giving them.
Orange one.
Purple.
You have to make 2 crosses.
Blue, please.
You need to be pre-observed.
The orange.
Sometimes it's all red. Put the time on.
Sorry, purple.
You want which one? This one?
Blue, please. Blue, please.
Green one.
Orange.
This is the blue one. Orange one, please.
Are you done?
Yeah.
The last
Blue
one.
one.
Thank you.
Orange one, please.
The last one.
Can you do it one by one?
Keep saying done when you're done. You're also done?
Orange.
Blue, please. Blue, please.
I'm lapping it
Oh,
here.
you're using technology.
Come on.
I'm done.
Who else done? Are you done?
I'm done.
Hey, okay.
No, but now I'm looking at times.
They forgot the procedure now.
You've established a very valuable surgical implant by throwing it.
He's disqualified actually.
Terrible doctor.
He's done only 3 years of MBBS.
9.5.
Alright, just sit tight.
3 years.
Stop, stop.
Okay, so we've got 2 lines in place.
Only 3 years and come.
Oh, this is the first guy, this is the last guy.
Correct.
I have to get patient once.
Okay. Somebody who hasn't been doing the exercise, would you just be a quality control of the information that's been provided? So we need to check what each of our teams of surgical experts, whether they meet the quality standard for the information required. So have they replicated exactly what's in the middle?
If they haven't,
Then we count the number of defects. Yeah. So I think 2 and 3 are pretty good.
4 is not okay.
4 and 1, and 1 is completely a different mark. It's a cross. It's a cross instead of a
Tilted cross.
This is the wrong surgery.
But this is information, so we've got the. So what it probably looks like is we've got about an 80% right first time.
where? With 1%.
Well, two. That one's quite difficult as well. It's
There are 5 people doing it. Like, are we all nominated?
So 3 out of 60%. My arithmetic is wrong. Sorry. So we could put 60% right first time. So observers, please look in the eyes of the patient. If you were going through that process, would you have a smiley face or would you be
Scary face.
Yeah, you'd be terrified. So I think we can put a sad face on there. Yeah.
Can I reset the clock?
Of course.
We don't have to give this.
We'll just save the time.
No, they're already recorded. Yeah.
Scary face.
And so we need a scary face in there. I think if you which face I pull it.
I'll use.
Red pen.
Whichever pen.
Orange?
Pink, please.
Okay. Very good. So, if we were to stick with the craft process, how would we improve the time to get the patients through, the first and the last? What would be the one thing you could do to make it much quicker to get the patients through?
More resources.
Yeah, more pens. Would that be affordable? Yeah. So
Not just that, more meat.
Yeah, we would need more store people to handle them. We would need more space. Yeah. So scaling up craft by just increasing resources to get a higher output level is rarely affordable, and probably we'd probably get deterioration in the right first time because again we'd have more variation, more handling. Even if we weren't having to rush in between the pens, we'd have, that's a great face, that's fantastic. So craft is clearly not really the way we think is the best way to handle healthcare and to handle our patients, because apart from anything else, even if that wasn't a surgical error, it meant the information system has got a problem in it, which means we might be billing incorrectly, our quality management systems have got the wrong information going into there. So again, it would add to even more challenges and problems. JCI or ABH would be quite worried about the outcome of that. Perfect. Okay, batch. And by the way, these simple techniques to convince people to use flow are very quick to learn. You can actually make up what the process is based on your level of your expertise. Is it in the laboratory? Wherever, use your subject matter expertise to convert what these crosses are into something that is meaningful in the area that you're trying to share it. I've used ear case because it's quite simple to describe that, and it's something that would lend itself to flow. So, we're now going to change and have batch. We've had a bit of an industrial revolution, and we know that we have to cope with more patients, so we can't afford to just add more resources to make craft work faster. Okay? So now we're going to go to batch. Okay? So we still have 10 patients, but what literally we're going to have now, and are you all happy to keep doing the same role?
Yep.
But it's a slightly different one now. Okay? Number 1 is now registration. Number 2 is pre-op assessment. Number 3 is operation. Number 4 is post-op. And number 5 is discharge. We still have our hospital information system role here. We no longer have a store, because at least with batch, we can now dedicate the pen to each stage. So we can give the pen to each stage. You've lost your job. You're now going to be a CI, continuous improvement facilitator. Yeah? So we can make sure we have the right pen in the right. So we haven't increased the number of pens. We're doing it now with the same resources in terms of our equipment resources. Okay? But we're going to do it in batch. So very simply, when we start, when we start, now this is still going to be a push process. You're going to issue 10 post-it notes. So so 10 patients have been scheduled to arrive together, not in your nephrology clinic, because you've already beaten that. Very good. Yeah, 10 patients are going to arrive together, so 10 post-it notes go into the first stage. You're going to put the first 2 crosses on each post-it note. Okay? And then you will send that, you will push that to the pre-op assessment.
One thing we didn't check was how many patients were actually cleared in the first step. So in craft, here we're doing 10, right?
It's 10. It's still 10 patients in the day.
We're doing this one too. Okay.
Yeah. That's 2 activities for each patient. Yeah. 2 pieces of information we're recording for each.
Correct. So we had 1, 2, 3, 4, 5, 6 patients.
5.
No, 5.
Sorry, 5. Yeah. And in this one we're going to have 10. So we're going to have twice the number of patients.
Oh no, good spot. We only did 5, didn't we?
Yeah.
Thank you. So we've now halved the list size to 5. Thank you. Very observant. Not 10, 5. I apologise. I'm pleased somebody's paying really good attention. Thank you. Good thinking. So we're going to issue 5 patients into the process. Yeah. 2 crosses for all 10 post-it notes, pass it on to add the next 2 sequentially through the process. Time for the first, time for the last. We'll do a check on the process quality. I think it will probably improve now that we know that we're being inspected. And because in craft it doesn't really get inspected, at least in batch there's a successive inspection, where we start to understand it, and let's see how it feels from a patient perspective as we go. Everybody 100% clear?
Sure.
Okay?
So all 5 should be passed together, not one by 10.
All 10 passed together, because we're moving the patients through the all 5 through the process.
But still double process, like 2 activities per patient.
Yeah, because it's 2 pieces of information we're recording. Okay? Everybody totally clear?
Yes.
3, 2, 1, go. You can't start until you have all 10. You can't start until you have all 10. They're all arriving together. 5. Please give the briefing. I'm going to blame it on jet lag. Others have a dementia.
And you can't pass till it's all.
No, you have to do all 5.
So everyone's having tea till the night he finishes.
Yeah.
Better you remove the previous one.
Only the first.
You've now got patients lying on top of each other.
Yeah, real useful. That's what.
Technically, it would continue, right?
Yeah, you get another batch of
Only the first time, no?
The first
Only
one.
the first time it's empty, right?
No, I don't want to distract the people writing, but actually in the batch, if we've scheduled 5 patients in the first list of the morning, yeah, then that's it, it's 5 people. So these people wouldn't be sitting doing nothing in reality, they'd be doing another task. They're doing, once they're finished, they're doing another task. They usually are not backing time for the next arrival of the patients because it's very difficult to balance workload in that way. It's not a factory.
Okay.
So the first 2 times.
The very first one that's done, so did you catch the first one or did you miss it? We're on the 5th. No, the first one complete.
Yeah.
Yeah, but we need the time when he completed the first sticky note of all 5 crosses and the time of the last.
Oh, I didn't know.
If you put the last one down, it looked like about 30 seconds between the 2.
Yeah.
Yeah? And could we put the patients or the patient...
Can you go back and check the video time?
Quality?
Clear? Just check. You can't check the time? What is the duration of this video?
15 minutes.
This one.
This whole,
Last one.
maybe a couple of minutes.
Just look at.
Yeah, so maybe a couple of
Yeah,
minutes.
yeah. You can run it again.
Tell us
Exact time, like at what?
Just go back.
Guys, are there any defects on the information that's been completed for the patients?
Fairly fine.
Pretty good.
224.
So at least by
224.
creating...
2 minutes 24 seconds. 2 minutes 24 seconds.
Oh, it's 5, so 1:30, that's me, so that's 2 minutes 24.
No, this was 2 minutes 24.
No, the total time.
Yeah, total time, which is that, yeah.
Yeah.
Okay.
Then that probably makes sense. I mean, I'm not too worried about that difference in time. So are we saying we think we now got at least a better information system going? Yeah?
Is that 100%?
I think so. Is everybody happy? That's conformity? Yeah.
That's because of the training we got.
So batches, yeah, and in every successive time you run a process, it gets better, goes without saying. How did it feel like the patients, all 10 arriving, sitting, waiting to go through each step? Would they still be happy?
Like the US visa experience.
All 5 of them?
First maybe with the last one.
Yeah.
Like the US visa experience, you know? They make you work together and make this.
So would it be fair to say it was less stressful, but still not a happy face? It's still, that's a really mad face. It would still be a fairly unhappy face with that. If you were the patient, you were sitting waiting between each. Yeah.
A lot less stressful for the operators.
Yeah.
More quiet.
Right.
Yeah, actually,
That's good. Yeah. So this is better for the operator, but it's still not better for the patient. And who pays for the wages of the operator? The patient. Yeah. So flow. Normally we make the flow in a U shape, but we'll stick with the circle. So the 5 stages are still the same. Reception, pre, op, post, discharge. hospital information system. You're still, you're a continuous improvement system because you corrected my statistical error. So that's very good. So he's been very observant in the process. Quality standard remains the same. What we're going to do now is run it in flow. So the first patient is entered singularly.
And then I pass the name.
No, then I pass it to her.
And she
And then-
asked,
Yeah.
and he asked.
So now this is the pull principle.
Okay.
You cannot pass him the next one until he has passed it, until the space is free, until he's finished to take that over to there. That's your pull signal to provide it. Yeah? Yeah. Similarly, you've got to be observant about what your colleague in the process is doing, and actually don't start one if they're taking longer than expected to do the other. Otherwise, it's creating it. Because we want to find out there's a break in the process, it's slowing down as we go. Okay?
In other words, you cannot pick up another one till that one is accepted.
Or it's, you can see it's almost complete, it's synchronized together, isn't it?
Almost,
yeah. Yeah. And that's why it's important to be able to visually manage so that we can see that. Whether we physically see it with our own eyes or it's a light. Some people use a coloured light, green, ready, go. Right, that means they're 10 seconds, 15 seconds away from completing the task. So we don't leave the patient to another queue. They move and they're ready to be accepted straight away. And all the evidence shows that that's much less stressful and it is much more positive as an experience and efficient. Okay?
But doesn't that mean that we'll have to control the arrival of the patient?
Yes.
Yes, so that may be the one place that you have a small batch because it depends on the transport they use. But as I said, there's more than one hospital made for a day case unit have made a specialised parking area to make it simple. Feeder care even have valet parking, which some hospitals here have as well. But they literally had it for the day case where they wanted to work very quickly, where minutes counted.
The smaller batches.
Yeah, more regular no batches. So it'd be, you would calculate the batch based on the probable error in arrival rate. Yeah? And that's actually, anybody who heard the word Kanban yesterday? That's all about the Kanban principles. What's the potential deviation in the arrival rate that you cannot control?
Right.
And that's at the point where you can have a minimal smaller batch because it's impossible to control the variation. Over time, if you find the variation is diminishing, you can reduce the size of that
But
process.
also in this case,
One more thing I just wanted to, when you talk of the batch, look at the scenario of the lab. If you have certain investigation, you say it's very, I have to open the kit, I must do this much.
That's right.
Otherwise the cost will go high.
Correct.
That's why some of the tests which are there, it's a results after 3 days, not today.
Yes.
Because they want to have the batch accordingly. Now there are 3 possibilities. One is many hospitals, they buy the stuff because it's like you are buying but 50% you are not using it. Same, it requires semi-auto analyzer, but they buy auto analyzer. It requires so much. Third one, if you really don't really have that kind of a batch, then you refer it to somebody, you don't do it. That's why the bulk which is coming to Lal lab, because we have done something in Lal lab, is okay because he's getting all the bulk from all over which the hospital are not doing. Even he's not doing some of the tests. They are going to abroad. Because that comes once a while, it's much cheaper than rather than create all the infrastructure. So that decision management also have to take.
In our electronic medical record, as soon as the dialysis is booked, the patient gets an SMS. Your dialysis is at 7:10. So there's no reason for the patient to come at 7 o'clock and occupy the reception.
Yeah, so they're pulse signals, isn't it? It's a pulse signal. 7:10, we're ready for you. Please come now. Some areas I've seen on very high volume day case units have a little Starbucks at the entrance. If they arrive early, they go for a coffee or a tea, depending on if it's meal by mouth, of course. But often for at least for their relatives if they've come with them. So they don't come and crowd up the waiting area because they're early. And we pull them then from the cafe into the operation process, of course, making sure we do meal by mouth.
it's very
But
important to have a
sometimes-
batch going because, especially in a case in a hospital or in a clinic, because your biggest, most expensive resource is the time of the doctor. So
And the OT, if it's a day case surgery.
You rather have the patient waiting and have some batch going there rather than like making it just in time, right?
But just in time uses Kanban to cope with variation. So it's just in time from Kanban to Kanban.
But
Yeah.
you'd rather have a batch in the.
But it's no longer a batch, it's a Kanban.
Okay.
It's controlled by a flow rate with a controllable thing. So that's a huge difference in theory about how it operates. So we don't have a chance in this course to cover Kanban, but anybody who's used Kanban, there's a lot of conditions that you actually have to operate to make it work. So this is, I wouldn't call it the acceptable batch, it's the unavoidable batch when there's variation in arrival that you can't control.
Right.
Yeah, but it's controlled by those conditions.
So there are some factors.
One more thing is, the application is also nursing activity in the ward. The head of the nursing decides now that you are dedicated to one person. If it is ICU, 1-to-1. Second one is no, you are dedicated to 1 to 4 people, batch of 4 patients, and you look after everything. Teamwork, whatever, nursing people. Another one is no, one takes all the blood pressure of everyone, another one takes all this, that, etc. So that also you have to balance which one is better to the body.
Depends on the.
Now there is, every system has some plus minus. Now, some of the thinking is that I get used to a nurse if she is dedicated to 1 or 2 people. Every time 5 nurses coming, somebody taking this, so you have entirely indifferent kind of a thinking. So there are psychological elements which also you have to look into the patient in the hospital cases, which doesn't happen in the factory. Factory is all conveyor belt is going around and then things are moving, etc. So you can see that.
Yeah.
There will be some limitations for implementation of a flow system. In my OPD, in consulting, patients come one by one. They give their blood sample and then they go to the lab. But then to centrifuge, you need a batch. So then they are kept holding till.
Yeah. So
that centrifuge
now
becomes the bottleneck.
No, yeah, so now you work on the bottleneck.
Yeah.
We can halve the sample size in a centrifuge without making it more expensive. Yeah, we've done it in so many labs where we you put less samples and you get them flowing through more regularly. The initial reaction is, I need more centrifuges. No, they usually need less.
Yeah.
Because they're getting more consistent flow as we operate them through the process. So you're absolutely right, sir. The more you create flow, the more you find the next bottleneck. You then apply the flow process to that bottleneck. So you remember the diagram you see, the pathway, the value stream, and the support services? Yeah? So the flow won't work unless the support is working at the same pace. Until it works perfectly at the same pace, there may be a little bit of batching until you eliminate the bottleneck.
Yeah.
But that's still much better than complete batching all the time. And it's a control, but we make it more of a Kanban control batch.
So in this example of the centrifuge, will the cycle time of the centrifuge determine how your batch should be?
Yeah. And the tap time. And how many resources you have.
Very interesting. We did same thing in the lab. At the collection center, they have a small centrifuge. Chief of pathology said, no, you must have a big one and you must have here. They are not capable of doing it, they are not this, that. We told now it's all bunk. They should do their job and send it here. That's much better. Rather than create a, now I think you create another problem. You don't have so much of samples here. So that is all. So there are many times you also have to debate from the scientific end.
So the other way you make sure flow processes work is when you have a problematic patient. And this is what the manufacturing guys do. It goes on to a different route. We don't forget the patient, but we stop it holding up. So we designed a whole new set of birthing suites for mothers in a maternity unit. And one of the problems always was you get a complicated birth that you couldn't predict. Yeah, it was just much more complicated from that perspective. Probably with more data you can predict it, but at the time they were predicting it. So we actually they had 6 birthing suites, and we made 1 for the complications. Yeah. So immediately we didn't move them from the suite, we switched the status of the birthing unit from being flow to complicated, knowing that it wouldn't flow, it would take a lot longer, and we wouldn't know how long it would take we all know, I'm sure some of you had children, My wife took 22 hours for our last one, and you couldn't guarantee how long that would be. So you make sure you put them into a different flow, which doesn't flow as well, but it doesn't matter, it's a small proportion of the total. What generally happens in healthcare is the problems then stop the entire flow because we still have to take care of them, and then the backlog grows and grows and it becomes very difficult. So by having an alternative route that we can put the complication through, which doesn't mean physically moving the patient, it just means how we move the resources, the flow could still be maintained. Yeah, if we're very small and we only have one birthing suite, it's more difficult. Yeah, but if we have two, we can think about how we have the designation of that suite as we go. Right, let's run batch and let's see
One more thing I just wanted to latest what is going on in the general physicians. He saw you, he knew family well, he knew you well. Then he refers you to A specialist. What happened in corporate hospital now? He said, endocrinologist. I know this much. You have hypertension, go to cardiology. The chap will go to 7 super specialists if required. What is coming back now, as you know, is a family physician concept. It is because you are being treated like commodity. If the carpenter in my house was making a table, I can blame the carpenter. That's all. But now when the concept of ready-made clothes or furniture, somebody is making leg, somebody is making your top, etc., whom do you blame? So the concept again in everywhere in the industry, like Raymond's has started, that whatever standardization of the ready-made, much better. Now they are saying there are tailors, go there, and they do it. They already started that. The quality is better, satisfaction is better, and you can get things done. So these are, one also should understand that quality, patient satisfaction, with cost has to be considered. Family physician is much cheaper than 7 super specialists who trying their own stunt on the human being, yet nobody has an answer for it.
I think this also calls for collaboration in healthcare. Because if you have a case which is going to take too much of your time, then it's better than 4 or 5 specialists come and create a special case like unit where you can push the patient.
Yeah, complex
cases. Yeah. Rather than trying to manage them with the routine cases.
So that's the one time you push it because they're breaking the flow and they need that level of proper care. But then we keep the other patients going through the process. So the satisfaction always improves because the majority of the patients are still going through the process, fine, they're in the expected times, and the patient who had the complication is still getting great care. So it's no compromise required. Okay, let's run the flow process. So one patient at a time. We shouldn't be starting on the next patient until we can see that the next step is almost complete, so that we're avoiding the patient queuing through the process. We'll take the time for the very first patient that's completed, all 10 crosses onto there, and then we'll take the time for the last. Sure. And then we'll take a look at the quality. Everybody ready? Yeah. That's only a second, don't worry. It comes down to a second.
About
So stop there, right? When
Yes, when the first one's finished, you take the time.
done?
Yeah, that's enough. Thank you. Very good. You spotted the process stop and didn't pass the patient on. Very good. It's complete. So the 2 times, and pencil to halfway. "29 seconds. So that is another whole experience, isn't it? Because the quality is good. Do we get the right information?
Yeah.
First,
29.
second one.
Second one is the
That's 10 seconds.
Yeah. And I actually deliberately stopped the process just to see whether the pull system was working, which it did. So we lost a couple of seconds whilst I just held on to that patient.
Use good.
100%. There's a patient where you're very cost conscious, your time is very important to you. Would that be a smiling face?
Yes.
To make it big.
Right. So we now need our new CI, continuous improvement facilitator, to help us make the next level of improvement. So what was the one, well, there was a number of wastes, but what was the biggest waste that was still in that process?
In the last one?
Yes.
Not just in time, like being able to.
Well, I think it was just in time, it was working between, but there was, it's along the same lines. What was the waste that we experienced?
Signaling.
There was still some waiting at the start, yeah? So there was still waiting at the start. So signaling we could cover. Yeah, so until the line was full of our patients, you weren't all active.
And then towards the end when
And
the
then
last
you
one had passed.
yeah. So, the flow theory creates what we call standard work in progress. Okay? So what that actually means is, how do we ensure that everybody is absolutely productive? So there's two ways of doing it. Yes, the clinic, the day case starts at 9 o'clock in the morning. You arrive at 9 o'clock, 8:45, you're ready to go. You may not arrive for another 15 minutes. You may actually have in your standard work other activities that you're undertaking, but you know you have to be there in time for that handover of the process. Yeah? So when we don't have very high volumes, we then make sure that everybody in the process is actively engaged. So if we come to the surgery, the clinician may have actually done a very quick ward round and checking on a couple of patients that he needed to do, but he knows he or she needs to be there in time for that process starting, because everybody's totally aware of how it all flows together, and if one person is not there on time, the flow process stops. And this level of improvement we got here, this is great. This is that's so powerful when you think about it, and it's not unrealistic into what would happen in real life from that perspective as we would get. The other way we can do it when we have higher volumes, and if we just talk about information processing rather than the patient processing, is we'll actually have a record, if we call this a medical record, in the process already from overnight. So when everybody starts in the morning, it's like, right, we've started the button, the process is working again, and therefore your utilisation of your time and effort will be much more effective. Now, that is much more effective than the other option of people starting the process at a certain time, because the risk is they don't make it on time to do their stage. There's always a risk of doing that. So the greater the throughput, the greater the volume, the Arabin model, where there's so many patients going through, we can actually then create that continuous flow of people coming through the process to be the most cost effective. Does that all make sense? So there's been some fantastic conversations about how do we achieve flow, especially where there are potential delays in certain parts of the process. So some of the solutions we've discussed are a secondary path for the complicated patients who weren't originally planned to be complicated. Similarly, and I'm not a doctor, so you'll probably tell me I'm wrong in what I'm saying here. Similarly, if we want to create a flowing process, we shouldn't start the day with what is probably the most complicated patient. Because if we get a delay, then it's going to knock on the whole day, even if we have a point of being able to put them down a different route. So, sorry?
How do we know this?
That's where the expertise of the doctor can come into case, yeah? When you've got a really expert, so even if you have a day case unit and you have one absolute master of orthopedic surgery, and they have colleagues who are not yet as experienced, the master is helping look at the list and saying, yeah, I think we should have that there person, that one there. Because that's their expertise. That's when we really get the greatest value out of their decision-making skills and capability. The junior learns from that process also. So we're now teaching more and more how we can create the right decision making. So this is the one decision flow. So again, prior to that, you're right, the doctor and the OT is a very, very expensive resource. So let's make sure we have all of the conditions absolutely right before we start at 9 o'clock in the morning. We've got the cart ready so we can think about all the things we need. So we're going to be doing a knee replacement. So we've already got the cart with the prosthesis. It's for a male adult, so we know the right size of mask to use. We've got the glove, we've got everything ready to go for that process, because in the surgery, we're ultimately looking for the minimum time between the last close-up and accounting for all of the instruments. We haven't left something inside the patient to the first cut on the next. It's like Formula One pit stop. Definitely. It's actually a great way of thinking about, if you want to have the most effective surgical unit, think about Formula One methodologies. How did they do that? You know, they do things in an unconventional way. If you've ever watched it or had experience of it, when they change the wheel, they've not got a spanner taking each wheel and off as they go. They have two different guns. One is empty, they put it on and the old one comes off. The other gun's already got nuts in place that it goes straight on again when the wheel goes back. They don't waste any time in that critical few seconds of actually having to do something differently. And we can do the same with our flow processes of, when we want to really keep this flowing at the right level, how do we prepare really well to ensure that we have everything in place at the right time, in the right quality, with the right information, so that nothing stops us. Make sense? Thanks for doing that, guys, but wow, 2 minutes 10 to 29 seconds. If you do that in whatever you do in your organisation, if you can get that level of improvement, that is so much capacity. You've got to really think about what you're going to do with it. It's a game changer, as they would say.
So when you are doing the process for patients, there are 5 stations, for example. Each station can prepare for the patient arrival. So if the 7 o'clock patient, dialysis patient walks in, 6:50 station number 1 should be activated.
Yeah.
Meeting with a junior and a senior and reciting what activity they need to do.
Yeah.
And that is one way in which our juniors could be trained. But
Yes.
they would run and recite the same mantra day in and day out as they move from one station to another station.
Dr. Singh can correct me if I'm wrong in this, but that's how Devi Shetty created his cardiac line, wasn't it? The juniors do all the workup and the prep for that, yeah? So they're learning to become really experts, and then they're developing that so that the most experienced heart surgeons are doing what they need to do. They know the workup and everything is absolutely right and spot on. Everything's ready and available.
They don't have to go back and check.
No.
The chances of errors are only reduced.
Oh, completely, because they've set the standards and that standard is repeatable and followed. Fantastic. Now, this was easy because each step had 2 crosses, right? What if step number 2 had 4 crosses and each of the other steps only had 2? How would we keep the flow maintaining at the same pace so there were no cues?
Put 2 people. Step number 2.
Yeah, so that's what we call line balancing.
Okay.
That's what we're going to do next. so it ties in perfectly together. And by studying our processes, creating our standard work, we can then look at the assignment of people and the assignment of tasks. So what we're going to do next, up until lunchtime, is we're going to learn a little bit about how we balance lines using standard work. I mentioned it this morning, we're going to use a real example of some work I did in an urgent care centre setup where they took external walk-in centres. I don't know if you've ever seen them, where they have a nursing staff but no doctors, and then they also had urgent care units, and they realised the walk-in centres were just sending patients to the ED anyway. They were adding a step to the process and they were still coming to ED as it stood. So we created a better urgent care, combined urgent care centre, which had a doctor, had all of the nursing and other allied health professionals to move them forward. So we're then going to give you a chance to do some exercises based on one of the live scenarios, and then I can show you what the answer was afterwards, so that it's not hypothetical, it's realistic. Good? Perfect. Right. Thank you for doing that, guys. You are now video stars. You will be on the